Hey, thank you so much, Chantel and the Gerontology Network, for this opportunity to share our research project with you. And I also thank my team members who were most closely involved in this presentation. Joy Birabua from the Department of Human Development and Family Studies, UNC Greensboro, and Shayna Gleason, Department of Gerontology, University of Massachusetts, Boston. Our We acknowledge research support and we are grateful to the National Endowment for the Arts Research Grant Program and UNC Greensboro, the School of Health and Human Sciences in particular. And we're also grateful to you for joining us today and to listen to our presentation and share feedback with us. We have a large team which is in different parts of the United States. However, it's the top three of us, myself, Shayna, and Joy, who are doing the bulk of the work, and the others mostly operate in a consultative and supportive capacity. Arts on prescription, if you are not familiar with the term, refers to the practice of healthcare practitioners writing prescriptions for patients to participate in arts programs. And art programs are widely defined, and healthcare practitioners are widely defined. Arts on prescription is one type of social prescribing. Social prescribing is where healthcare practitioners write referrals for patients to access non-clinical, non-pharmacological programs that are often community-based to promote health and well-being. In 2022, Morse et al. Published a comprehensive global review. They described that social prescribing has roots in the 2008 World Health Organization Commission on the Social Determinants of Health. At the person level, social prescribing can give individuals the knowledge, skills, motivation, and confidence to manage their own health and well being. At a systems level, social prescribing is a pathway for healthcare systems to address social determinants of health. At the society level, social prescribing can facilitate greater collaboration across health, social, and community sectors to promote integrated care and move beyond the traditional biomedical model of health that has proved to be very costly and yet leaves gaps in results and coverage. While the term social prescribing was first popularized in the UK and the first plans were developed and implemented there, this practice has become more prevalent and widely publicized internationally over the last decade, with 17 countries included in Morse's review and more joining since then. Our study specifically examines, number one, how social prescribing for the arts, what we call arts on prescription or AOP, affects older adults, OA, access to arts participation. The background of our study draws from a large body of literature where the World Health Organization's 2019 review of the subject suggests that at all ages, arts participation promotes physical and psychological well being. Oopsie, excuse me. Yeah. And it plays a role in preventing, treating, and managing health conditions. Regardless of an older adult or any person's level of ability, arts participation can buffer against a variety of negative outcomes, can be a pleasant and rewarding pastime, and be a lower cost, non pharmacological approach to prevention and treatment. Public health experts recognize the role arts participation can play in supporting an aging population. Both participatory arts activities, such as painting, dancing, playing an instrument, acting, and cultural attendance also known as arts consumption, for example, attending a museum, a concert, or a play, may be beneficial. Our study thus includes both of these under the broad heading of arts participation. I would like to emphasize that this is distinct from art therapy. Societies including Canada, the UK, EU countries, Australia, and others have adopted arts on prescription initiatives to increase access to art participation for patients with various physical and/or mental diagnoses. Social prescribing creates a referral pathway from a healthcare practitioner to a range of non-clinical services, often through a link worker who has extensive knowledge of local services and providers and have the time to spend with patients to gain knowledge of their interests and match them with appropriate services and programs. Link workers are called different names in different countries or sectors. In the US, a link worker might be called a patient activator or navigator. The broad umbrella of social prescribing has been used for many domains, including diet, exercise, social connection, and arts. Social prescribing has the potential to reduce healthcare costs related to management of multimorbidities and overburdened primary care systems, especially for aging populations. In the US, some government funded social prescribing efforts have focused on other areas of need like food security, food boxes, lower cost fruits and vegetables, or exercise programs. Community health centers, with funding bolstered by the 2010 Patient Protection and Affordable Care Act, connect patients with non medical services such as those just described to influence the social determinants of health. However, the arts have yet to appear in force on the American social prescribing scene. While some arts therapy activities deemed medically necessary are covered by health insurance, coverage is limited outside of inpatient settings and psychotherapeutic context. In the US, arts participation for adults occurs mostly through the private and philanthropic sectors. This has been shaped by an age imbalance, as arts funding typically prioritizes youth and professionals. Arts programs for amateur adults have comparatively limited budgets. Overall, only about 2% of American institutional philanthropy goes to aging programs, as noted by Featherman in 2018, a figure that has scarcely changed for more than 20 years. A study by the National Endowment for the Arts in the US indicated that people aged 65 and older are less likely to participate in various forms of arts compared to younger age groups, and about one-third of Americans of all ages did not think that there were plentiful opportunities for arts participation available in their community. People of lower education and ethnic minority communities were less likely to participate in the arts. In the realm of arts and health, this indicates a substantial gap in the policy climate and treatment options for older adults. Although the US lacks universal publicly funded healthcare coverage, most older adults, that is around 93%, are covered through Medicare, private insurance, military insurance, and Medicaid. These systems cover a range of preventive care services such as annual wellness visits, screenings, immunizations, diabetes self-managements, etc. But arts or prescription has not thus far been implemented. Because most older adults in the US have access to Medicare or other insurance, arts on prescription may be feasible to incorporate into a health insurance plan for older adults. Here are our research questions. They fall under two broad areas each with subparts. Please notice the focus on older adults, on participation in arts via arts on prescription, and the study of funding mechanisms and policy frameworks. That is, we are not covering established ground by assessing the value of arts participation itself. That has been established in prior studies. So we consider what is existing research found out on the effects of arts on participation for the health and well-being and arts participation access of participating older adults. How do marginalized and underserved older adults access potentially beneficial arts participation through the arts on prescription mechanism? How can preventive care, wellness visits, or similar existing mechanisms be used to provide access to arts on prescription within the health insurance system available to older adults in the US? Could arts on prescription be a preventive and or a curative treatment option? In the US, what are the practical and policy feasibility considerations for health insurance programs that cover most older Americans? What resource structures would existing community arts organizations need to handle potentially increased numbers of older adults receiving arts on prescription? And again, how would marginalized and underserved older adults participate through arts on prescription programs? To address these questions, we are following two methodological streams. First, we are conducting a scoping review of the literature to understand the scope and volume of research on our questions. For those less familiar with this method, a scoping review is a form of knowledge synthesis that is often a precursor to a systematic review. Nevertheless, it uses rigorous methods to uncover and synthesize existing information on the topic of interest. We do not evaluate the evidence base to inform practice. We point out findings and gaps and suggest future research. We are following the PRISMA steps to conduct a scoping review as laid out by the Joanna Briggs Institute of Canada, that is among the most widely known models in this field. We have registered our scoping review protocol with the Open Science Framework platform. Second, we are conducting individual in-depth interviews with key informants overseas in countries where arts on prescription is widespread. These include arts program developers, health policy experts, medical practitioners, patients, and link workers. We followed the PRISMA scoping review methodology to conduct the literature review, and here are some of the steps laid out. First, we developed a list of search terms, consulted with a reference librarian. Then we circulated the list of terms among the full research team for input. Then we pilot tested the search terms, reviewed them again in consultation with librarian and other research team members. Here, I would like to express our team's gratitude to the UNC Greensboro Jackson Library reference librarians who assisted on our project, especially Amy Hauk and Sam Harlow, who are very skillful and have been very generous with their time and expertise on scoping review protocols. After we refined the search terms, we submitted them for a formal review through a PRESS form to the librarians and gained another round of input from them. Then we conducted the search on various databases, including EBSCO, CINAHL, PubMed, ProQuest, JSTOR, and Google Scholar, because we are including published peer-reviewed articles and what is called gray literature, such as conference presentations, technical reports, newspaper articles, articles that are in press and just shared on a public archive and other such forms. We saved the search results in a reference management software, that is Zotero in our case. We eliminated duplicates, and then we screened the results to include or exclude. And then we extracted data from the included results. So this is kind of what that looks like. We identified 1,759 articles searched online and saved in Zotero, eliminated 797 duplicates. 65 additional readings were suggested by team members. So we have 1,027 selected for review. 3 team members read the titles and abstracts and recommended to retain or remove. And we discussed any differences to consensus. Then we created a data extraction spreadsheet. The data extraction spreadsheet was also piloted with a few selected studies and discussed for what domains of information to include. And then we discussed to consensus. For example, the original domains included study population numbers, study population by age, study population in terms of disadvantaged communities, the study methods, the findings as related to our research questions, notes, and if a decision was made to further include or exclude. After piloting the spreadsheet, we added the domains of what definition of arts on prescriptions was used, funding models, and what domains relevant to our study were covered. For example, did they include arts on prescription and older adults, or social prescribing only, or some combination of these? This last domain is very important because through our study identification process, we ran into the challenges of first, how few studies seem to directly address our research question and study population of interest. So we included those that even seem to hint at them. And second, many titles and abstracts sounded like they may be relevant, but they seemed to leave out some important information to us, such as the age of the participants. So on our first screening, we included doubtful cases, and then in a secondary screening, we would further include or exclude. Thus, the data extraction spreadsheet is an important tool for our secondary screening. This is the PRISMA flowchart that is being put out for use by researchers that lays out step by step the same information that I talked us through in the previous slide. And this is what we will include in a final publication. In this flowchart, the term records covers everything: articles, reports, gray literature, etc. Yeah. So let's come to our emerging findings. We're still in the middle of our research process, but we have some emerging findings to share with you. From the literature review, based on impressions from our preliminary reading and data extraction of selected articles, we have some emerging findings. There are few studies based in the US, since arts on prescription is yet to fully emerge here. More studies are found in UK and Canada and other countries. Fewer studies focus on older adults who are often included in a general adult population. We have studies where the age range is 18 through 89. And then we have to read in depth to see what the average age is or whether very few people are in the upper age range. Most studies are qualitative with limited generalizability. Arts on prescription is described differently in different countries and by different individual practitioners or programs. So there is, in a sense, a wide umbrella, which is part of the philosophy of social prescribing, but it also means that we have to make sure where we are in this whole spectrum. The feedback is generally positive. The effects of arts participation or the effects on arts participation of prescription are generally positive. And the effect of this pathway on the well-being of older adults is positive. In general, let's see. All right. Most studies consider how arts on prescription benefits participants, and they focus on how arts participation improves well-being. Our first research question also focuses on how the arts on prescription pathway benefits patients' well-being. Since there is already a substantial research record on how arts participation itself well-being, but fewer studies consider this particular pathway. And fewer studies still consider how arts on prescription increases arts participation of older adults. They kind of just jumped over and say, okay, here's the arts on prescription, and those who participated are doing fine. So that intermediary step of would these people not have accessed any arts participation if it hadn't been prescribed? That is often missing. We had to read and interpret closely to extract available information. Disadvantaged, excluded, underserved, or marginalized older adults are less often explicitly considered or recruited for studies or programs. Some studies do address this, as the study setting was specifically in areas comprising diverse marginalized older adults. However, many studies typically view disadvantaged in terms of health conditions, disabilities, older age, isolation and loneliness, etc. So there is an umbrella of disabilities and an umbrella of disadvantages. Funding is a gap in every sense of the term. Published studies often don't discuss how arts participation or arts on prescription are funded. Some studies and programs are grant funded for that research study, or they are funded through philanthropies. An ongoing arts access after the program ends or after the study ends is an issue. This raises an overall question as to how much arts participation is envisioned through arts on prescription versus through a participant's own interest. For example, if 12 art sessions are prescribed for a person, at the end of that time, are they prescribed more sessions to maintain their well-being, or are they expected to continue participation through their own initiative and resources? This may be a challenge for people with limited resources, but continuing prescriptions open-endedly may be a challenge for the system. We have also just begun analyzing our key informant interviews. To date, we have completed 25 individual in-depth interviews, 11 in the UK, 10 in Canada, 1 in Denmark, and 5 in the US. We have only one participant from Denmark because arts on prescription is still in the early stages there. However, we are seeking additional participants from there. Our participants include researchers, link workers, policy and advocacy experts, arts programs developers, and participants. What we see is that the definitions of social prescribing and arts on prescription are broadly similar despite program variations by country, region, and province. The focus is on a referral pathway from healthcare to arts participation. Recall that this is not art therapy. This is community arts participation, whether as an active role or as a consumer or audience member. So a person in Canada said that they see this as a way of referring a citizen to a non-medical activity in the community, and that's very broad. Social prescribing comes in very different framework. Sometimes a healthcare person is prescribing, sometimes it's somebody else, it's a social worker. Sometimes you don't even need a prescription. You just go to the activity because you heard about it. And at this point, we wonder then how is it arts on prescription? But we're still looking at that. A UK participant also said, if somebody wants to refer themselves, we're completely receptive to that because the whole point is empowering people. So we try not to have barriers to access. We try to keep entering the program as simple as possible for as many people as possible. Interviewees were generally positive about the benefits of arts on prescription for patients. This contributes to patients' well being and their actual need and want to be in and feel part of something. The conditions that were most often referred were for patients who had mild to moderate conditions and mental health diagnoses associated with repeat primary care visits that were expensive and did not yield a clear benefit for the patient. So, low level anxiety, low level depression, low level loneliness, or isolation. So, it appeared that these patients could benefit from additional support. Some neurological conditions could include Parkinson's disease, which benefited from dance and movement programs, or psychiatric conditions such as anxiety or depression, or societal challenges such as loneliness or isolation that might be somaticized. Even in countries where the idea of social prescribing and arts on prescription has been in operation for a while, there are structural challenges in program design and delivery. Arts organization and community organizations appear to be in the forefront. And while physicians who were interviewed for the study were enthusiastic about the benefits of arts on prescription, the overall health system seemed to have some challenges to work through. So somebody from Canada said, the health sector is not really used to working with the cultural sector. Even at the government level, we have silos. This is a new way of thinking that's really coming from the grassroots. To get up to the top of the structures takes a while, but it has to be taken on by somebody who thinks this is a good idea politically. It's not going to happen unless there's political will. A person in the UK pointed out some cumbersome aspects of the National Health Service. Various people say how difficult it is to get the NHS and the arts to work together structurally. The NHS is a huge beast. It employs 1.5 million people and has loads and loads of little component parts which all behave in slightly different ways. But it is hugely trusted by everybody. It is the number one most trusted institution in the UK. And even with the current pressures, there's a huge amount of public goodwill towards it. But because it is so big, it changes very slowly. And it has these antiquated systems. And arts organizations tend to be much better at innovating, being fleet of foot, and pivoting on a sixpence to the kind of thing when needed. Some key informants also describe shortcomings in outreach and access of diverse participants. These showed additional gaps in the system with regard to involving people who might be historically excluded from healthcare systems. A Canadian participant said, I think when people have been writing about the wellness element of the museum, I question who they're studying because it might be the folks who would feel the most comfortable there, which happen to be the non-racialized visitors. Another person from Canada said, we had a partnership with the United Way who invited priority neighborhoods, which in Canada are neighborhoods that require more support because of socioeconomic status, also because of being sites where many newcomers come to live, so needing more social systems there. Lots of people have lots of trauma with the healthcare industry. A third person from Canada said, this region is very multicultural and we don't have resources to offer an interpreter for our program, which means there's already a huge proportion of people who don't have access, which is not great, but that's how it is. Other informants who were interviewed and some of the literature reviewed described that social prescribing in general or arts on prescription cannot plug holes in the social safety net system, such as lack of housing, lack of heat, low income, high food costs, cuts in the healthcare system, etc. Funding is an ongoing challenge. Across almost all the interviews and in many of the reviewed studies, funding of arts on prescription and social prescribing is ad hoc and patchwork. The healthcare systems fund doctor visits and to some extent funds link workers. The arts programs themselves are funded through a mix of philanthropic funding, research grant funding, local arts council funding, and other sources that are typically temporary. As described by a UK interviewee, some gaps in the existing funding system can reduce or be a barrier to accessing arts programs. So the person said, if patients are going to clinical appointments and don't have transport, the NHS will fund that. There's actually quite a big patient transportation system. But they won't fund them to come to one of our groups, for example, and that's an arts group. In Canada, a person said, the idea of just applying for ad hoc money and project money is difficult to keep the sustainability. But it's also difficult to get money for these projects because they are in between the arts and health, and not that many foundations. You're either supporting health or supporting culture and arts. And they're like, but what are you? What kind of project are you? Yeah, but we are sort of in the middle. But as a Canadian participant also reminded us, it's never really a question about money, is it? The money is there if the willingness is there. It's about priorities. As I have already described, philanthropy funding for arts focuses on youth, and funding for older adults focuses on health. The arts and you and health connection is less recognized, and the interests of older adults in arts is a gap. There seems to be an ageist lack of vision here, and it is indeed a question of priorities. There are creative and lower cost or no cost ways in which arts programs are funded. If arts on prescription gains momentum, arts organizations will have to find ways to sustain the increase in clientele. Some programs have a combination of private pay and grant paid participants. This might work in some situations, but will pose other kinds of challenges. As said before, when does arts on prescription cease, and when do people take up participation from their own interest? And where does funding cover all of these? A Canadian participant said, we have had therapeutic dance, art therapy groups, and those were paid usually through grants. Or we would sometimes, if we had an art therapist doing a placement at our center, she was earning credits for her school, but was able to offer some of these programs. And we would always, like even with the Ottawa Symphony Orchestra, I wrote to them and said, oh, would you be interested in offering free tickets to your concerts to our clients? And they were like, yes, because they would rather have the seats full. And in the UK, the person said, half our salaries for the link workers come from the NHS. Our program money, our delivery is funded by a specialist arts fund and by our local authority. And we, as part of that, also do training. So we have a network of arts and health practitioners, freelance artists, and we support them with a network with training, mentoring, conferences, that kind of thing. Our next steps are to complete the scoping review process and write and disseminate that manuscript, complete key informant interviews in overseas countries and their counterparts in the US, analyze and disseminate the funding, and we hope that as an end goal of our study, that your practitioner will one day be able to prescribe arts programs for you, or your community organization might do that, or you might be able to self-refer. We welcome questions for us at this time or later, and we look forward to hearing more from all of you. Do you have any contacts or connections you can help us make to get our interviews proceeding? And yeah, we would be grateful for any questions. I'm going to stop sharing now, and Chantel, maybe you want to transition from one recording to another. Thank you.
Perfect. Thank you so much, Dr. Shreenawa. I am going to stop recording now.